Introduction. Definition: a benign breast lesion which can resemble carcinoma. GM commonly affects premenopausal women with a recent history of pregnancy or breastfeeding. Symptoms typically include a painful breast lump, inflammation, abscess, and swollen lymph nodes. The clinical and imaging features of GM can resemble those of cancer, infections, or autoimmune diseases, making diagnosis challenging. Pathophysiology. Retention of ductal secretions in the mammary ducts. Damage to the epithelial lining causes leakage into surrounding lobular connective tissues. Trigger local inflammation involving lymphocytes and macrophages. Immune cells migrate to periductal area and produce cytokines. It trigger local granulomatous response. Patient profile. Women aged between 27 and 44 years old. Most patients were women. Who has given birth at least once? One patient who have never given birth. Time since last childbirth, 1 to 8 years. Median time was 2.5 years, 30 months. One patient was 6 months pregnant, and 2 patients were breastfeeding. Symptoms from the cases. Hard lumps 8 cases. Hard lumps progressing to abscesses 6 cases. Abscesses only 2 cases. Other symptoms. Locally inflammatory reaction. Nipple retraction. Swollen lymph nodes in the armpit. Diagnostic findings. 1. A cluster of epithelioid histiocytes and multinucleated giant cell. 2. A cluster of epithelioid histiocytes within a mixed inflammatory background. 3. Multinucleated giant cell within a mixed inflammatory background. Causes of granulomatous mastitis. Idiopathic GM. Pregnancy. Autoimmunity SLE. Diabetes mellitus. Specific GM. Bacterial infection. Infectious of tuberculosis. Fungal infection. Pregnancy. 1 patient was pregnant at the time of presentation. However, it is usually not the primary cause of granulomatous mastitis GM. Hyperprolactinemia. Another patient had hyperprolactinemia 8 months prior presentation. Systemic lupus erythematosus SLE. 2 out of the 16 patients had SLE upon presentation. Association of SLE with GM are rare, but there have been evidence of few recent cases. Others may due to an immune reaction or an infectious agent. Treatments of granulomatous mastitis. Excision and surgical drainage. For patients with lumps localized to upper outer quadrant of breast had excision. 7 patients had 11 surgical drainage. Surgical excision with administration of steroids in lesions were the best treatment method for GM patients. In patients who undergo extended excision, surgery often leads to large breast tissue defects with healing issues. Steroid medication. 2 patients received steroid, variable results. During the topical steroid treatment, the inflammation signs in the affected breast had markedly disappeared, the fistulas had become inactive, and the fistular orifices and/or skin erosions had closed. Antibiotics. All patients were given antibiotic, some given several courses. Antibiotics were our preferred first-line medical therapy. Follow-up period, 18 months to 4 years for 15 of 16 patients. Lost to follow-up, 1 patient was not tracked. Lump excision outcomes. For patients had no recurrences after lumps were excised. Symptom resolution. Symptoms subsided in 3 to 8 months, median 6 months. Recurrences. 1 patient had 3 recurrences at 7, 13, and 24 months. 1 patient had a recurrence after 24 months. Disease course may require multiple operations and become inactive over months or years.